Chapter 41, Introduction to the Sensory System. TIMBY, Med-Surg, starting on page 705. Learning Objectives. Describe the anatomy and physiology of the eyes. Discuss tests that are used for visual screening. Identify questions to ask during an eye assessment. Describe diagnostic studies for eye function. Explain the anatomy and physiology of the ears. Describe methods for assessing the ear and hearing acuity. Describe specific diagnostic tests for ear function. The special senses of vision and hearing allow humans to view their world, hear what it is in their environment, communicate with others, and maintain their balance. Eye and ear disorders occur throughout the life cycle. Many of the disorders can result in changes in visual acuity or hearing loss, as well as problems with balance and communication. Nurses can be instrumental in early identification of eye and ear problems, and they may play an important role in reducing the severity and/or long-term effects of eye and ear disorders. This chapter focuses on the structure and function of the eyes and ears and the diagnostic tests used to evaluate their function. Anatomy and physiology. The eyeballs are globes located in the protective bony cavity or orbit of the skull. The frontal, maxillary, zygomatic, sphenoid, ethmoid, lacrimal, and palatine bones form the walls of the orbit. Fat and muscle protect the posterior, superior, inferior, and lateral aspects of each eyeball. The extraocular muscles that permit movement include the superior and inferior rectus. They move the eye up, elevation, and down, depression. The medial and lateral rectus move eye toward, adduction, and away from, abduction, the nose and the temple, and the superior and inferior oblique muscles rotate the around the optic axis, intorsion and extorsion. A seventh muscle called the levator palpebrae superioris elevates the upper eyelid. See figure 41.1 on page 706. 3 cranial nerves innervate the extraocular muscles. The trochlear nerve, cranial nerve 4, innervates the superior oblique muscle. The abducens nerve, cranial nerve 5, innervates the lateral rectus muscle, and the oculomotor cranial nerve 3 innervates the remaining muscles. Extraocular structures. The eyelids, eyelashes, and tears protect the anterior or exposed surface of the eye. The upper and lower eyelids are folds of skin that meet at an angle referred to as the canthus, C-A-N-T-H-U-S. The outer or lateral canthus is the outer angle, and the inner or medial canthus is at the inner aspect of the eye. The line between the lateral and medial canthus usually is horizontal. Children with Down syndrome have a line that slants upward and outward. People of Asian descent have an epicanthal fold, which is a fold of skin that covers the inner canthus. The eyelids protect against foreign bodies and adjust the amount of light that enters the eye. The eyelashes trap foreign debris. Periodic blinking clears dust and particles from the surface of the eyes. The eyelids have multiple glands, including sebaceous, sweat, and accessory lacrimal glands. They are lined with a sensitive, transparent mucous membrane called conjunctiva. This membrane extends from the lid margins and meets the cornea, the transparent dome-like structure that covers most of the anterior portion of the eyeball, at the limbus, L-I-M-B-U-S, which is the outermost edge of the iris. The lacrimal caruncle is a small reddish elevation on the conjunctiva located at the inner canthus. Tears composed of water, sodium chloride, and lysozyme, an antibacterial enzyme, are produced by lacrimal tear glands found beneath the bony orbital ridge. The lacrimal apparatus includes the lacrimal glands, punctum, P-U-N-C-T-U-M, lacrimal canals, lacrimal sac, and nasolacrimal ducts. Tears flow across the eyes, continually bathing and lubricating the surface. The tears drain through the punctum into the lacrimal canals and lacrimal sac to the nasolacrimal ducts, tiny openings at the junction of the upper and lower lids, and then into the nose. See figure 41-2 on page 706. Is this following statement true or false? The eyelids, eyelashes, and tears are responsible for clearing dust and particles from eye surfaces. This is false. Blinking clears dust and particles from the eye surface, and the eyelids, eyelashes, and tears are responsible for protection of the eye. Intraocular structures. 3 layers form the intraocular structures. The first layer is the sclera, S-C-L-E-R-A, commonly referred to as the white of the eye. It is composed of tough connective tissue. The sclera protects structures in the eye. It connects directly to the cornea, anterior chamber, iris, and pupil. The middle layer is the uvea, UVEA, or vascular coat of the eye, located immediately under the sclera. The uvea includes the choroid, choroid, which contains blood vessels and darkly pigmented cells that prevent light from scattering inside the eye, and the iris, the highly vascular pigmented portion of the eye surrounding the pupil. The pupil is an opening that dilates and constricts in response to light. The choroid gives rise to the ciliary body, composed of ciliary processes and the ciliary muscle. The ciliary processes produce aqueous humor, a nutrient-rich liquid that nourishes eye structures. The ciliary muscle helps change the shape of the lens when adjusting to near or far vision. The anterior chamber behind the cornea is filled with clear aqueous humor, which provides nourishment to the cornea. The lens lies behind the pupil and iris. See page 707. The posterior chamber is a small space behind the lens. Aqueous fluid produced in the posterior chamber by the ciliary processes flows from the posterior chamber to the anterior chamber. It then drains into the canal of Schlemm, S-C-H-L-E-M-M. Vitreous humor is thick, gelatinous material that maintains the spherical shape of the eyeball. It also maintains the placement of the retina. See Figure 41.3 on page 707. The retina, the innermost layer of the eye, is composed of a pigmented outer layer and an inner neurosensory layer. Light stimulates this neurosensory layer, which contains nerve cells called rods and cones. Rods function in night or dim light and assist in distinguishing black and white. Cones function in bright light and are sensitive to color. The nerve cells of the retina extend from the optic nerve. The macula lutea, L-U-T-E-A, or the yellow spot, is composed entirely of cones and allows for detailed vision. It lies in the center of the retina. The fovea centralis, or foveola, is at the center of the macula. The blood vessels are displaced from the fovea centralis, allowing light to pass to the cones. The density of the cones decreases away from the fovea centralis as the number of rods increases in the periphery of the retina. The optic disc, the anterior surface of the optic nerve, is easily distinguished from the macula because of the vasculature that radiates from the optic disc. No blood vessels radiate directly from the macula. See Figure 41.4, page 707. The macula is the area of the eye that provides central vision, the ability to discriminate letters, words, and the details of any image. If the macula degenerates or is damaged, only the ability to see movement and gross objects in the peripheral fields of vision remains. Is the following statement true or false? Rods and cones are located in the retina of the eye. True. Rods and cones are located in the retina of the eye. Visual function. The function of the eyeball is to convert light energy into nerve signals that are transmitted to and interpreted in the cerebral cortex. Every object reflects light. For a person to see it clearly, the reflected light must pass through the intraocular structures, the cornea, anterior chamber, pupil, lens, and vitreous humor. The room.
I'm getting all the competition from my brothers.
What do you mean?
4th of July festivals.
What do you mean?
Food.
What, are they sending you pictures?
Yeah.
What do you make? Or do you... Eye assessment. The ophthalmic assessment provides information about a client's eye health. Nurses usually examine the client's external eye appearance, pupil responses, and eye movements, as well as obtain information about the client's ophthalmic condition. For more complex examinations, nurses need additional education or training. Ongoing eye examinations and treatment require the care of specialists. Box 41-1 on page 708 provides a list of specialists and technicians who provide eye care and treatment. Clients often ask nurses when to have an eye examination. The American Academy of Ophthalmology, as of 2014, recommends that adults who do not have any signs of eye disease or risk of any eye disorders have a complete eye examination once in their 20s and twice in their 30s. A baseline comprehensive screening needs to be done at age 40 years because signs of disease and visual changes begin to occur at this time. Between ages 40 and 60 years, it is recommended that eye examinations occur every 2 years or as needed. After age 65 years, it is recommended that a complete eye exam occur every 1 to 2 years to check for age-related eye disorders. Adults with a personal or family history of eye disease, diabetes, or hypertension should see an ophthalmologist to determine how frequently they need an eye examination. Symptoms that require attention include bulging of the eyes, dark spot in the center of the client's field of vision, difficulty focusing, blurred, cloudy, double or hazy vision, loss of peripheral vision, or sudden loss of vision. Chapter 42 provides more information on eye disorders. What? Nursing assessment continues. The nurse obtains a history to identify any specific problems that the client is experiencing and possible causes. Box 41-2 lists questions that nurses may ask when taking an ocular history. The nurse gathers information related to eye problems, past and current ability to see, any discomfort, pain, or other symptoms, how long the client has experienced problems, any treatments and medications, and other illnesses that may affect eye health. The nurse in the acute care, outpatient, or home setting performs a basic assessment of ocular health by obtaining the following: client's description of vision changes, any visual or eye discomfort, use of glasses or contacts, use of prescription and non-prescription eye medication, previous eye trauma, ophthalmic and medical diseases and surgery, family history of inherited eye diseases such as glaucoma, allergy history associated with seasonal conjunctivitis, inflammation of the conjunctiva that often accompanies hay fever. Box 41-2, questions to ask during an eye assessment. Are you having any problems with your eyes? Do you have any problems with your vision? Do you wear glasses or contact lenses? Have you experienced blurred, double, or distorted vision? Have you any eye pain? Is it sharp or dull? Is it worse when you blink? Do you have any itching or feeling that something is in your eye? Is there any discharge? What does it look like? Color, consistency, odor. Are both eyes affected? How long have you had this problem? Has this happened before? What have you done to treat the problem? Does anything make the problem better or worse? What medications have you used to treat the eye problem? Do you have any other diseases or conditions? What medications are you taking? Have you ever had eye surgery? What and when? Do any family members have any eye conditions? After the interview, the nurse inspects the eyes for symmetry and also observes the lid margins for signs of inflammation, exudate, or loss of eyelashes. The nurse determines the pupil size and their change in response to light. Normal pupils are round, of equal size, and constrict simultaneously when stimulated. See Figure 41.5. The nurse checks the extraocular muscles by asking the client to keep his head still while following an object moved up, down, left, and right. Figure 41.6. Other observations include looking for ptosis, Ptosis, which is drooping upper eyelid, proptosis, which is an extended or protruded upper eyelid that delays closing or remains partially open. Nystagmus is uncontrolled oscillating movement of the eyeball. In addition, the nurse can examine the client for age-related changes in the eye. Table 41.1 reviews these changes. A cataract interferes with focusing and causes increased glare, decreased vision, and changes in color perception. It does not affect central vision. Any related macular degeneration affects central vision. Visual screening tests. The Snellen eye chart, figure 41.7, is a simple screening tool for determining visual acuity, the ability to see far images clearly. With the chart 20 feet away, the examiner asks the client to cover one eye and identify letters of decreasing size. Results for each eye are expressed as a fraction that compares the client's vision with standard norms. If a client has 20/20 visual acuity, which is normal vision, it means that he or she sees letters at 20 feet that others see clearly and accurately at 20 feet. A client with 20/40 vision sees letters at 20 feet that most others can read at 40 feet, and so on. For clients who cannot read or do not read English, a tumbling E-chart is used. It is set up like the standardized Snellen chart but uses E's with the fingers pointing to one side or another, or up or down. Clients are asked to indicate which way the fingers are pointing. If the client cannot identify even the largest letters on E's on the chart, the examiner asks him or her to count the number of fingers that the examiner holds up. If the finger count is inaccurate, the examiner tests the client's ability to distinguish light from dark. Visual acuity is also measured with a computerized refractor that records the strength and type of lenses necessary to correct the client's visual problem. The Jaeger chart and Rosenbaum Pocket Vision Screener evaluates near vision. These charts contain words, numbers, and letters in various print sizes. The examiner instructs the client to cover one eye and then hold the chart approximately 14 inches away and read the smallest print that he or she can see comfortably. The size of the print the client reads indicates the quality of his or her near vision. Color vision is assessed with the Ishihara polychromatic plates. The client receives a series of cards on which the pattern of a number is embedded in a circle of colored dots. The numbers are in colors that colorblind individuals commonly cannot see. Clients with normal vision readily identify the numbers. Age-related changes in the eye, eyelids and lacrimal structures. The structural changes that occur: loss of skin, elasticity and orbital fat, decreased muscle tone, development of wrinkles. That's the structural change. The functional change is turned in lid margins, entropion, and turned out lid margins, ectropion. Client reports burning and sensation of objects in eye. Increased tearing, inflammation, ulceration may also occur. Refractive changes. Presbyopia. This is the structural changes the lens cannot readily accommodate with aging. The lens develops opacities. The functional change is the client holds reading material at increasing distance to focus. Findings. The client reports needing increased light, needs reading glasses or bifocals. Cataract. Structural change, lens develops opacities. Functional change, interference with focus of a sharp image on the retina. Client reports increased glare, decreased vision, and changes in color perception. Conjunctiva. The conjunctiva, the white portion of the eye, becomes slack and more susceptible to chronic inflammations with age. Part of the conjunctiva may become caught between the lids during blinking. Harmless degenerative plaques may appear on the conjunctiva, tear glands, and the conjunctiva may lose the ability to lubricate the eye. No particular findings. Cornea, the structural change, arcus senilis, a harmless white circle that may appear on the margin of the cornea, is a common occurrence in older adults. Functional change. Composed of cholesterol and its derivatives, its presence does not necessarily indicate an overall increased cholesterol level. no complaints. Posterior vitreous detachment, structural change, liquefaction and shrinkage of vitreous body. Functional change may lead to retinal tears and detachment. Client reports light flashes, cobwebs, and floaters. Age-related macular degeneration, yellowish aging spots in the retina called drusen, D-R-U-S-E-N, appear and coalesce in the macula. Functional change may lead to retinal tears and detachment, affects central vision, see chapter 42, and affects reading vision. The posterior vitreous detachment may lead to retinal tears and detachment. The age-related macular degeneration affects central vision. Extraocular muscle function tests. Corneal light reflex test. The corneal light reflex test assesses the alignment of the eyes. The examiner holds a pen light approximately 12 inches from the client's face and asks the client to stare straight ahead. The reflection of light should be in the same spot on each eye, indicating parallel alignment. If the light reflex is uneven, it indicates deviated alignment of the eyes, possibly owing to muscle weakness or paralysis. Cover-uncover test. The cover-uncover test assesses extraocular muscle function. The examiner asks the client to stare straight ahead and focus on an object in the distance while covering one eye with an opaque card. As the eye is covered, the examiner observes the uncovered eye for movement. The examiner then removes the card and observes the previously covered eye for movement. The test is repeated on the opposite eye. The client's uncovered eye should remain fixed on the object in the distance, as should the eye that is covered and then uncovered. If there is movement, it may indicate a deviation in alignment and muscle weakness. Positions test. The positions test, or cardinal positions of gaze, is done to assess eye muscle strength and cranial nerve function. The examiner asks the client to focus on an object that is approximately 12 inches away and moves this object through 6 cardinal positions in a clockwise direction. As the object is moved, the examiner observes the client's eye movements, which should be smooth and symmetrical in all 6 directions. If asymmetrical movements are noted, it indicates weakness in the extraocular muscles or dysfunction of the cranial nerve that innervates this muscle. Is the following true or false? The Snellen chart assesses for color vision. The answer is false. The Snellen eye chart determines visual acuity, whereas Ishihara polychromatic plates assess color vision. Diagnostic studies. Extraocular muscle function tests, already been covered. Diagnostic studies. Ophthalmoscopy. Direct ophthalmoscopy is an examination of the fundus or interior of the eye. This examination is done with a direct ophthalmoscope, an instrument that illuminates the internal surface of the eyes and allows the examiner to see the lens, retina, retinal blood vessels, and the optic disc under magnification. See Figure 41.8 on page 711. Indirect ophthalmoscopy involves the use of an instrument that produces a bright, intense light. The ophthalmologist uses this instrument in conjunction with an ophthalmoscope to see larger areas of the retina, although no magnification is involved. Retinoscopy. Use of a retinoscope and trial lenses determines the focusing power of each eye. A retinoscope is a handheld instrument that produces a line of light. The light appears distorted in the eyes of clients with refractive errors. Trial lenses of varying refractive powers are then placed in front of the eye until the light streak does not deviate in any direction. Tonometry. Tonometry measures intraocular pressure, IOP, to screen for glaucoma. It is done by using a tonometer to indent or flatten, applanate, the surface of the eye. The principle is that a soft eye indents more easily than a hard one. The force that produces indentation is measured and converted to a pressure reading. Normal IOP is 12 to 22 millimeters mercury. High readings indicate high IOP, low readings indicate low IOP. Again, IOP is intraocular pressure. There are various methods for performing tonometry. Appellation tonometry provides the greatest accuracy, but the indentation method may be used because it is smaller and more portable. Before either is used, a topical anesthetic solution is instilled in the lower conjunctival sac. Anesthesia begins almost immediately and lasts for a few minutes. The client does not feel the tonometer while the eye is anesthetized. A non-contact tonometer, although less accurate, blows a puff of air against the cornea and no local anesthetic is required. Visual field examination. A visual field examination or perimetry test measures peripheral vision and detects gaps in the visual field. The client fixes his or her gaze on a stationary point straight ahead. A light or bright light is moved from a point on the side where it cannot be seen toward the center. The client indicates the point at which he or she sees the stimulus without directly looking at it. Certain disorders such as glaucoma, stroke, brain tumor, or retinal detachment are associated with changes in the visual field. Color vision testing. Assessing a client's ability to differentiate color is essential for determining a person's ability to function within an environment dictated by color codes. For example, traffic lights or work equipment mandate that people be able to distinguish different colors. Ishihara polychromatic plates are the most common test for color vision. Different plates bound in a book have dots of primary colors embedded in a background of secondary colors. Clients must identify the hidden shape. Clients with diminished color vision are not able to do this successfully. For these clients, a quantitative colorblind test may be used. These tests have trays with discs of various hues. The client is asked to arrange the discs in a continuum of the gradually changing hues. Quantitative colorblindness tests help to distinguish the severity and type of colorblindness. Amsler grid. Clients with macular problems are initially tested with an Amsler grid. It is made up of a geometric grid of identical squares with a central fixation point. The examiner instructs the client to stare at the central fixation point on the grid and report if they see any distortion of the squares. Clients with macular problems may say some of the squares are faded or wavy. Slit lamp examination. A slit lamp is a binocular microscope that magnifies the surface of the eye. A beam of light, narrowed to a slit, is directed at the cornea, facilitating an examination of structures and fluid in the anterior segment of the eye. This examination is used to identify disorders such as corneal abrasions, iritis, conjunctivitis, and cataracts. Retinal angiography. Retinal angiography or fluorescent angiography is used to detect vascular changes in blood flow through the retinal vessels. Sodium fluorescein, a water-soluble dye, is injected into a peripheral vein. The examiner uses a special camera to photograph the appearance and distribution of the dye in the retinal arteries, capillaries, and veins at 1-second intervals. The photographs provide a record of vascular filling and emptying defects. Many conditions affect retinal circulation, such as diabetes mellitus, hypertension, drug toxicity, tumors, and AIDS. In addition, lack of macular capillary perfusion or abnormal growth of new vessels around the macula, called neovascularization, as in macular degeneration, can be detected. Intravenous fluorescence causes skin to yellow slightly for 6 to 8 hours. The urine also turns bright yellow, but the color becomes less noticeable over the following 24 to 36 hours as the dye is excreted. Indocyanine green may be used instead for the contrast agent in order to visualize choroidal vasculature abnormalities with the use of digital video angiography. Ultrasonography. Ultrasonography is used when pathologic changes such as an opaque lens, cloudy cornea, or bloody vitreous make it difficult to look directly at the posterior of the eye. Using sound waves, the contour and shape of contents in the eye are imaged and recorded. After installation of anesthetic ophthalmic drops, an ultrasound probe is placed on the cornea and a recording is made on an oscilloscope. This technique is helpful in detecting eye lesions and measuring for an intraocular lens implant before extracting a cataract. Laser scanning. An ophthalmologist An ophthalmologic screening tool uses a retinal imaging system to produce a high-resolution image of almost the entire retina without having to dilate the pupil. The panoramic 200 scanning laser ophthalmoscope can detect retinal disorders such as diabetic retinopathy and provides an excellent baseline screening test. Nursing management. Although nurses may not be directly involved in caring for clients who are undergoing eye examinations and tests, it is essential that they engage in ensuring that the clients receive eye care to preserve their eye function and/or prevent further visual loss. Careful assessment of the function and structure of the eyes provides the nurse with a baseline and assists with determining if further action is warranted. See Evidence-Based Practice 41-1 regarding visual impairment and aging. This is on page 713 in Chapter 41. Visual impairment, aging, and safety. Does visual impairment increase with aging and become a safety factor? Evidence. In today's world, the population increases with aging, people live longer, and there are more diseases that occur earlier, such as diabetes and high blood pressure. All of these factors increase the incidence of visual impairment and can cause disabilities. A community-based population survey study was completed on about 5,000 participants over age 60 in China. The survey asked how visual impairment impacted the use of stairs. The study concluded that people over 60 years of age had some difficulty using stairs, and that stairs were included in most for activities of daily living, and therefore planning ahead for clients and educating early would be helpful. Nursing implications. Nurses can use this evidence in their education and discharge teaching to make sure that older clients or clients with visual impairments are linked to necessary resources to decrease fall risk. The ear's anatomy and physiology. Ears are sensory organs serving two primary functions, hearing and balance. Speech development and preservation are dependent on hearing, as is communication. The ability to have balance or equilibrium is also dependent on ear function. This includes having coordination and ability to change positions and move safely. The ear is divided into three areas: the outer, middle, and inner sections. See Figure 41-9, page 713. Sound is perceived because of a chain reaction involving all three areas of the ear. The inner ear also helps maintain balance. The outer ear and middle ear transmit and amplify sound, referred to as conductive hearing. The inner ear's receptive organs are stimulated by the sound waves, hearing, and by head position or movement, balance. This is also referred to as sensoroneural hearing. Sound is also conducted through skull bones to the inner ear. This pathway is not as effective as air conduction. Outer ear. The outer ear or auricle consists of the pinna, the fleshy external projection of the ear, and the external acoustic membrane, or meatus, a 1-inch canal that extends to the tympanic membrane or eardrum. The outer ear collects sound waves and directs them inward. The external acoustic meatus contains the glands that produce cerumen, a waxy substance that lubricates the ear canal, protects the eardrum, and helps prevent external ear infections. Chewing and talking help to move cerumen to the outer area of the external acoustic meatus, where it is easily washed away. The outer ear transmits and amplifies sounds as it travels down the ear canal, causing the tympanic membrane to vibrate. Older clients form drier cerumen and experience an increased incidence of impaction in the external acoustic meatus. Non-prescription preparations are available for softening hardened cerumen. Refer the client to a healthcare provider if hearing remains diminished. Middle ear. The middle ear is a small air-filled cavity in the temporal bone. The eustachian tube extends from the floor of the middle ear to the pharynx and is lined with mucous membrane. It equalizes air pressure in the middle ear. A chain of three small bones, the malleus, the incus, and the stapes, collectively referred to as ossicles, stretch across the middle ear cavity from the tympanic membrane to the oval window. They move when struck by sound waves transmitted from the outer ear. When these bones are set in motion, the footplate of the stapes, which is very flexible, strikes the oval window, agitating the fluid in the inner ear. The inner ear. There are two sensory systems in the inner ear: the auditory, which is hearing, and vestibular, which is balance. The inner ear, or labyrinth, consists of a series of cavities and canals that contain fluid. It contains the cochlea, which provides for hearing, the semicircular canals, which promote balance, and the vestibulocochlear nerve, cranial nerve 8. The fluid motion created by the vibrating stapes excites the nerve endings and the sensitive sound receptors of the organ of corti located in the cochlea. The impulses are then converted to nerve impulses and transmitted along the cochlear nerve or auditory or acoustic nerve to the brain where sound is perceived. Nerve receptors for balance, motion, equilibrium, and spatial orientation are found in both the vestibular and semicircular canals, the vestibular system. They transmit information about motion through the vestibular nerve, which joins with the cochlear nerve to form the 8th cranial nerve, the vestibulocochlear nerve. The sense of equilibrium is also reliant on vision and the stretch receptors in muscles and tendons, so that the equilibrium is maintained or restored when head position changes or movement occurs. Response to body imbalance is fast and depends on reflexes. Vestibulo-ocular reflexes keep the eyes still while the head is moving, and vestibulospinal reflexes permit the body to either maintain or regain equilibrium. Question: where is the pinna of the ear located? Outer, middle, inner, outer, and middle. The answer is the pinna is the outer part of the ear, and it is located again in the outer ear. Ear assessment. The screening of hearing in adults is generally voluntary. General recommendations for asymptomatic adults include screening at least every decade through the age of 50 years and every 3 years thereafter. Although family practice physicians assess and treat many ear disorders, they refer some clients to otolaryngologists, physicians who specialize in the diagnosis and treatment of ear, nose, and throat disorders. An audiologist is a paraprofessional with special training in performing hearing tests, measuring hearing loss, and recommending methods for improving the perception of sound. See Box 41-3 to outline the nursing assessment. Obtain client's appraisal of his or her hearing, including whether the client experiences tinnitus. Observe for actions that suggest a hearing problem, such as leaning forward, turning the head, or cupping a hand to the ear to hear better. Document the use of a hearing aid. Ask clients about allergies, a history of upper respiratory and middle ear infections, high fevers, or exposure to loud sounds, because all these signs can cause hearing loss. Inspect external ear for signs of infection, such as swelling, redness, drainage, or evidence of trauma. Shine a pen light into the ear to grossly inspect the ear canal. Straighten the ear canal by gently pulling the ear up and back for an adult and down and back for small children. Palpate the areas in front of and behind the earlobe for tenderness and swelling. Perform a basic hearing acuity test. Pharmacologic considerations. Could impaired hearing, tinnitus, or vertigo be caused by a drug? Taking medications such as furosemide, which is a diuretic, chemotherapy, salicylates such as aspirin, and many antibiotics can have hearing adverse effects. Medication reconciliation can discover if drugs are the cause of hearing loss. Basic auditory acuity tests. One general method is to assess a client's gross auditory acuity. The method is referred to as the whisper test. For this test, the examiner covers the untested ear with his or her palm and stands 1 to 2 feet from the client's uncovered ear. He or she whispers a number or a phrase and asks the client to repeat it, providing several numbers to ensure valid test results. Another technique is to sit behind the client and bring a ticking watch toward the ear. The client should perceive the sound at the same time as the nurse, who is assumed to have normal hearing. Otoscope examination. An otoscope examination involves inspecting the external acoustic canal and tympanic membrane using an otoscope, a handheld instrument with a light, lens, and optional speculum for inserting into the client's ear. See Figure 41-10 on page 715. If normal, the canal appears smooth and empty. The normal tympanic membrane is intact, looks pearly gray, and transmits light. Excessive cerumen or wax interferes with inspection. Tuning fork tests. A tuning fork is an instrument that produces sound in the same range as human speech. It is used to screen for conductive or sensorineural hearing loss. A conductive hearing loss involves interference in the transmission of sound waves to the inner ear. Sensorineural hearing loss is the result of nerve impairment. The Rhine test and Weber test identify types of hearing loss. For the Rhine test, see Figure 41-11, the tuning fork is struck, placed on the mastoid process behind the ear, and held there until the client indicates the sound is no longer heard. Immediately after that, the still vibrating tuning fork is held beside the ear, and the client again says when the sound is no longer heard. Normally, air conduction beside the ear measures twice as long as by bone conduction through the mastoid. The Weber test is performed by striking the tuning fork and placing its stem in the midline of the client's skull or center of the forehead. See Figure 41-12. A person with normal hearing perceives the sound equally well in both ears. If the sound seems lateralized to one ear, it suggests a conduction hearing loss in that ear or a sensorineural loss in the opposite ear. Gerontologic considerations. Careful documentation of conduction times assessed using the Rhine and Weber tests is important. This information enables early identification of hearing changes and may affect selection of assistive hearing devices. The Romberg test. The Romberg test is used to evaluate a person's ability to sustain balance. The client stands with feet together and both arms extended. The client closes his or her eyes. Swaying, losing balance, or arm drifting are abnormal responses. Because central nervous system lesions cause similar abnormal results, additional testing is needed to confirm an inner ear dysfunction. For clients who are unsteady, this test may not be appropriate. For all clients, the examiner needs to be close by to prevent the client from completely losing his or her balance and falling. Diagnostic studies. Audiometry. Audiometry is done by an audiologist. Audiometric testing measures hearing acuity precisely. During the test, controlled intensities of sound measured in decibels, dB, are projected to one ear at a time through a headset. The client indicates when the sound is heard. The lowest level of sound that normal individuals can first perceive is 20 decibels. Painful sounds occur at 120 decibels. The sound of a jet engine would register around 180 decibels. Hearing acuity is determined by measuring the intensity at which a person first perceives sound. Table 41-2 provides a description of hearing loss severity measured in decibels. There are two other aspects to audiometry: frequency and pitch. Frequency is the number of sound waves per second that come from a source. It is measured in hertz, abbreviated Hz, or cycles per second. Frequency ranges from 20 to 20,000 hertz for humans. Normal speech range is 500 to 2,000 hertz. Pitch refers to frequency. A tone of 100 hertz is low pitch, and a tone of 10,000 hertz is high pitch. Severity of hearing loss, Table 41-2. 0 to 15, normal hearing. Greater than 15 to 25, slight hearing loss. Greater than 25 to 40, moderate hearing loss. Greater than 40 to 55, moderate hearing loss. 25 to 40 is mild hearing loss. 55 to 70 is moderate to severe hearing loss. 70 to 90 is severe hearing loss, and greater than 90 is profound hearing loss. Caloric stimulation test. A caloric stimulation test assesses vestibular reflexes of the inner ear that control balance. Warm water, 40 degrees centigrade, or cool water, 25 degrees centigrade water, or air is instilled into the external meatus of each ear separately. The fluid alters the temperature of the temporal bone and creates convection currents in the fluid of the inner ear that stimulate movement of the head. Nystagmus, a quivering movement of the eyes, is the expected response. Slight dizziness may also be experienced. A diminished response in one eye is significant for an inner ear disorder such as Meniere's disease, discussed in Chapter 43. Electron nystagmography is a more precise method for evaluating vestibular function, the mechanisms that facilitate maintaining balance. It is performed in conjunction with caloric stimulation. When the fluid is instilled within the ear, a machine records the duration and velocity of the eye movements with electrodes attached superiorly, inferiorly, and laterally about the eyes. Nursing management. Often testing and care of ear function are done in outpatient settings. Assessment of ear structure and hearing function is done as screening in most healthcare settings, providing a foundation for further testing and referrals. Nurses can be instrumental in identifying hearing loss early in initial assessments when clients are admitted to a healthcare setting. Refer back to box 41.3 for questions to ask clients and for observations to make when assessing clients. In addition, identifying risk factors for hearing loss is important. Risk factors include genetic predisposition, congenital anomalies, history of frequent or prolonged otitis media, fluid in the ear, loud noises, including sustained exposure to loud noise or short exposure to sound greater than 110 decibels, ototoxic medications, viral inner ear infections, and impacted cerumen or wax. This is the end of the slideshow.